just goes to the origin.
Okay.
Welcome, everybody. Thank you for coming today. My name is Linda Napier. I've been with the League of Women Voters for 4 years now, and the chair and co-chair of the Healthcare Committee, studying healthcare around the world, and for the last several years, healthcare here in the United States. I have traditional Medicare.
I'm Carol Mattoon. I've been a League member for a long time. And I've been working with Medicare for All since 2008. And I have Medicare Advantage.
Hi, my name is Colleen Gray. I just joined the League probably about a year ago. The reason why I was asked is I actually got into this because of these two. They give a wonderful, great presentation, and it's very true to life. I actually started out as a nurse and ended up as a nurse practitioner probably for the last 25 years in the long-term care industry. I was also a vet, so the healthcare that I have, I just recently retired. I'm 62 and a half. So I retired, and what I chose was TRICARE Select, which is different than TRICARE for Life, and I also have VA benefits.
So just to give you a little overview of what the program's going to be, we're going to give you some history. We're going to talk about how we got where we are, where we'd like to go, what the fear factors are, and then when we get to the end of that, okay, you're going to be so inspired that you're going to want to do something. So we're going to give you some ways that you can be involved. And then Colleen is we're going to kind of give the facts and figures. She's going to give real life experiences with her being a nurse practitioner and all that she's done in the healthcare field. So she's talking about the real case scenarios.
Okay, so let's get going. Our presentation is going to be about the choices for the future of healthcare, and we'll also be going over some of the plans and proposals that the candidates are offering so that we can understand what our choices are. So just very, very quickly, this started back in 1912 with Theodore Roosevelt, and the presidents, Franklin Roosevelt, Harry Truman, the Fair Deal, they've all been working on this for a very long time to get universal health care. But then it took all the way from the early 1900s to 1965 when Johnson finally signed the Medicare and Medicaid bill for seniors over 65. And this was supposed to be just the first step. And then very swiftly they were supposed to go to lower ages and lower ages until everybody in the country was covered. But that incremental change did not happen.
So that was 54 years ago, and we're still waiting for that major incremental change.
So all the way then up until 2003, finally there was a bill introduced called HR 676.
So that was John Conyers and Dennis Kucinich that put that together. Doctors were really upset. Insurance companies were telling them how much time they could spend with a patient, what kind of prescription they could do, what kind of testing they could do. They were disgusted. So they wrote their own bill. They took it to Dennis Kucinich, John Conyers, and said, would you please put this in bill form? Which they did in 2002. And it was introduced every year since, until a couple years ago when John Conyers was now out of the Senate, and Jay Appel, who is a House person from Seattle, she took it on. So every year it was called 676. Well, last year she wrote the gold standard of Medicare for All, and that's House Bill 1384, and that's kind of what we're going to be talking about today.
I think what's really, really important about this is that it was originally crafted by physicians. And then, of course, 2010, we got the Affordable Care Act.
Which was considered another step.
And so the good news, we all know people really benefited. Pre-existing conditions were covered, Medicaid and subsidies were expanded.
The bad news is the medical costs have continued to rise, and the system is still complicated and inefficient. So you had the good and you had the bad. It was supposed to be an incremental step. It's now 10 years later.
So let's move on now to our current situation. When Carol and I first started doing the presentation, this slide said that our healthcare system was dysfunctional, and then it said it was broken, and now we've changed it to crisis, because everything we read, everything we study talks about our healthcare system being in crisis, and so many people understand that, and that's why there are so many people that are working so hard to get everybody covered and get healthcare into our system. So our current healthcare system, it's expensive.
There's massive billing operations. It's expensive for individuals. It's expensive for businesses. There's so much waste in there with administration. So it's on many fronts very expensive.
It's inefficient.
So we have millions of healthcare dollars that are going for administration, not for healthcare.
Very complicated. I think we all know how very, very complicated it is.
So one example is Cleveland Clinic. They have 210 million codes. So when you go see the doctor, they code it because that's how they're going to get paid. So they want to have as many codes as possible. So the poor doctors are getting very frustrated with this because they're spending the majority of their time not with their patients, but doing the paperwork that's associated with that. And so part of that is all this coding.
Unsustainable. This one's probably one of the biggest.
So that since 2009, the premiums have gone up 54%. So when we're talking about unsustainable, you know, they're talking about, well, what this healthcare program is going to cost or what that one's going to cost. They're not putting a dollar figure on, okay, if we just leave it the way it is now, it's going up so much every year that budgets of a lot of businesses and municipalities, 22% of their budget is going for healthcare for both the present employees and the retirees. So it's just not sustainable to stay where we're at today.
And it's not working for many of us. And what I'll do in the next couple of slides is I'll show you a visual to make the point about this being unsustainable. There it is, right there. This is one of my favorite slides. This right here, Jim made me this wonderful pointer. Okay, so back here, this is where, in a lot of the studies that Carol and I have looked at, there's 19 wealthy, industrialized countries that are usually studied. And here we go. And this is that line right here, of all those 18 other countries. Before that, healthcare in the United States was a service industry. I don't know why I forget that word. In 1973, a bill was passed by President Nixon that said now insurance companies, pharma, hospital, doctors, everybody could start making a profit. And you can see where that took us all the way up to over 18% of our GDP, where all the other countries that are giving health care for all of their people are hovering here around 11%. Okay. Okay, and I know everybody's heard about this one, but I thought a visual would be really, really interesting. So you know where everybody says it's $3.65 trillion is what we're spending on healthcare, and that they all say, and it's double what all the other countries are spending. Well, these are some of all the other countries. These are the countries that are being in these studies. Switzerland, there's Germany, Austria, France, Canada, Japan, New Zealand. So down at the lower end, under 4,000, and Switzerland up here at just under 8,000. But the average is, of all these countries that provide health care for all of their people, is the average of 5,221. So we are almost double at 10,209.
So it's projected in the year 2026 that it's going to be $6 trillion to keep it as is today.
Your money or your life.
Okay, so I think this pharmacist is saying your money or your life. And I think we all know too that we've heard about the insulin going up so fast. In 1996 it was $21. It was $275 in 2017. So here's one of the myths. We pay high premiums because we have the best healthcare system in the world. But when do all the research and you start looking at some of the studies, you see that the United States is actually down here at the bottom. Here's the UK up here at the top. This might mean a little bit to us later on. But no matter which study we look at, no matter which graph we look at, they may switch a little bit, but the US is always down at the bottom. And it's always about care process, access, administrative, efficiency, equity, and health outcomes. And I want to just tell you a little bit, when you see all this little teeny printing down at the bottom, that's all about our resources and where we're taking this information from. And also the health outcomes. The maternal death rate is increasing. Here's the United States. This is since 1990. The maternal death rate is increasing. All of the other countries are going down. Here's low health equity. African American women are more than twice as likely to die than their white counterparts.
So it's a racial and a social economic issue in the United States. There's a health care that's available, it's just not available to all people. So it's a multifaceted problem.
So I guess you could say that in many ways we do have the best health care in the world. It's just that the cost and the access to that health care is a problem. Especially a problem when you're sick, people that have to go and beg for money on GoFundMe. You're sick, your family's worried about you, and they have to go and figure out, how am I going to start a GoFundMe and how am I going to get this money to pay for these bills? So people are raising $650 million on GoFundMe each year to tax the rising costs of healthcare. And the CEO said 1/3 of the site's donations, 1/3 of their donations are for medical costs. So Americans rank surprise medical bills at the top of the family budget worries, and this is just February 2020. Carol and I try and update this right to the minute that we possibly can every time we give this presentation.
So the hospitals are getting really sneaky. So now when you go to the hospital, you're thinking all you had to know before is that you were in network. However, now they're outsourcing a lot of that. So there's people going home thinking that their insurance paid for their bills when really they didn't, and then they're going to be getting these astronomical bills afterwards. So it's saying people that went to the emergency room thinking that they were in network, 40% of the patients ended up with what they call a surprise. You're hearing that even in the ads now. Mm-hmm. So those bills average around $600. If you end up hospitalized, about 40 of the people get these surprise bills, and they're averaging $200,000. So these are significant. And these bills are coming from people that you can't say, you go to the emergency room and you go, whoa, wait, I need to know the anesthesiologist, and I need to know the pathologist and the surgery assistant. I need to know before I go into emergency surgery that all these people who's going to do that? You can't do that. So these are a lot of people that you're not even going to see or have the opportunity to talk to make sure that you're in their system. So this is the new sneaky way that hospitals are bringing in more profits.
The U.S. healthcare system is bad for business and bad for our country. When I first started reading about this, I didn't really take into consideration how bad it was for businesses, because we were interested in, the people, how it affects the people. But of course, when it affects people, it does affect the business of the people. It's bad for business due to the high cost of employee health care, because the medical insurance premiums have increased 54% since 2009. That affects what you can pay the workers. If you're paying the health care bills, it's very hard to then give your workers increases in their pay. It creates a competitive disadvantage in global markets. So there's an example I want to give, so I'll explain that in just a second. So this is a question that I think we asked that a lot of you have answered. What was the average annual premium for employer-sponsored health insurance? For a family of 4? So how many people, just raise your hand, how many said number 1, $7,500? This is employee and employer added together. About 10,000? about 15,000, 20,000 plus. Okay. The answer is 20,000 plus. The total premium increased 22% from 2014. And here's the example of the real life example. MCS Industries is the US market leader for wall and poster frames, etc., around the world. They have 200 employees, they've been in business forever, and he pays $2.7 million to cover their health insurance. Now that's $27,000 a year for a family. It's $13.50 an hour per employee for all of his employees, and it's 22% of his payroll. So can you see then how he struggles to compete and also to pay his people what they deserve, and they all work together. They all sit down every year and spend untold amounts of time trying to figure out what's going to be best for the employees and for the company to make everything work and they can still stay in business.
If we didn't have the Affordable Care Act, would the percentage of increase in
Wait a minute.
cost be more?
We'll probably answer all the questions as we go through, but I would just say,
Save your questions to the
save
end.
your question, but no, this includes the Affordable Care, because it includes insurance companies, and so, there we go.
So just kind of in summary, we know that a lot of the outcomes in the United States are poor. We know that insurance companies are still raising rates. They're soaring, their rates are, because they can. We know that hospitals are getting pretty sneaky about how they're making more profits. And we know that it's bad for business. Okay, so we've set up the problem. That's where we're at. So now let's look at some possible solutions that are being advocated by the various, when they asked us to put this program together because they wanted to know what each candidate was advocating. So we had all that, and each time somebody got out of the race, and so we're down to 3 candidates.
Within the last 2 weeks. Carol, you have to now delete. Now you have to delete. Okay, so here we go. Many plans are being offered under the universal health care. Does everybody understand what universal health care is? It means everybody is covered. They include protect and build on the Affordable Care Act. This would be grayed out because that person is now not in the race. Develop a public option and single-payer Medicare for all. These are the 3 options that are still being talked about by the 2 remaining candidates. So what are the key differences between Medicare for all, the Affordable Care Act, and the public option? Improved Medicare for all covers all the needs of primary care, emergency care, mental health, addiction treatment, prescription drugs, medical devices, dental, vision, long-term care.
So then you also have flexibility. You can choose your doctor, your hospital, so it's freeing you up to choose whoever you want in the medical field to go to.
And then it slashes that bureaucracy that we were talking about, the administrative paperwork, and they'll negotiate prescription drug prices and services. And that's a really huge part of the savings, is the administrative piece. 34% of your healthcare dollar goes for administration. You know, those people that are taken care of, you see when you walk into a doctor's office, that's just a little part of it, but it's an example.
And then you're going to eliminate your premiums, your co-pays, that supplemental insurance, your deductibles. It's all going to be covered. A lot of people say, well, they got insurance today, but they're underinsured. They can't afford to go to the doctor because they can't afford the co-pay. You want people when they're sick to go to the doctor because you don't want to get whatever they have. So under Medicare for All, you're going to eliminate all that. You don't have to think, do I pay for my food or do I go to the doctor? You go to the doctor if you're sick.
Okay, and then we have the Affordable Care Act. It's going to leave the basic structure the same. And then what's going to be proposed as the new piece is they're going to increase the amount of subsidies. So if they're paying $1,000, they'll pay you $1,200. But when I want to talk about this really quick. I didn't really understand subsidies until my sister, when it was taken in the middle of the night to emergency in December. I flew out the day after Christmas. She had an emergency operation the next morning. And I called her and I was talking to her and she says, "So let me send you this over," because I didn't understand, she's ACA, I didn't understand subsidies. So it's the amount of her silver plan is $2,366 a year.
A year or a month?
I'm sorry, a month, which is $28,392 a year. She pays $586.91. The government pays $1,779 or $21,337. This is her 1095A that she puts in with her taxes. They spell it all out.
So just add all that up. She's one patient that's getting subsidized that much a month, times how many people in the United States?
So when I say subsidies, and they're going to increase the subsidies, that's what I mean. So I just wanted to make that clear. They're going to put a cap on premiums, and they're going to extend the subsidy eligibility. So you know how now it stops at 400,000 over poverty? The proposal is 600% over poverty. So they'll extend the subsidies and increase the amount of the subsidies. Okay, now, public option. So, if you can't be on the Affordable Care Act, we're going to have the public option. And it builds on the ACA. It creates a brand new government-sponsored option. So that'll be another layer, another layer. It includes premiums, deductibles, and out-of-pocket expenses. It expands the number of people eligible to receive subsidies, decreases the dollar amount of government subsidies, increases. It increases benefits. The goal is to make the ACA less complex to navigate, can buy into even if your employer offers insurance. And the benefits vary by eligibility, payments to the provider, services offered, auto-enrollment for some groups, and premium and subsidy calculations. So this is the proposal for being able to cover everybody eventually.
Now,
So are these either or they go together?
They go together.
no. One's the Affordable Care Act. The other one is a brand new program.
Bonnie, it's a brand new program, but Joe Biden is proposing that it's either this one or this one, and now it will cover everybody.
With the two. So this, where it's the public option, he also calls it the Biden plan.
The
So-
buy-in plan?
No, Biden.
Biden
Biden
plan, sorry.
plan. So these are two different things. Now, in case you didn't catch what the similarities were to these two, these are for profit. So you got your healthcare dollars going again for profit, not healthcare.
Okay, so how does Medicare for All, the ACA, or the public option proposal affect our current Medicare program? Medicare for All replaces Medicare with Enhanced Medicare for All. So there's our inclusions again.
So those of you that are on Medicare right now, some people go, well, I'm gonna just keep what I have and that's what everybody else is gonna have. No, this is going to replace it and it's going to be better. So when people go, oh, I don't wanna lose my Medicare, why not if you're getting a better plan? Under this, you've got vision and hearing and long-term care. So, okay, the scare tactics that they're putting out there is, oh, you're gonna lose your Medicare. And your response is, great, because I'm getting more things.
Long-term care?
Yes.
Wow.
So under the ACA or the public option, there's no change. It will stay the same. It will stay the same. What happens to employer-sponsored and private insurance under Medicare for All? So this is another big question about the employer insurance. So under Medicare for All, it replaces the private insurance with the employer-sponsored. And then the employer-sponsored private insurance under the public option, it retains all of the employer-sponsored insurance. Now, there is a little piece here. Employees can buy the public option insurance if they qualify. There's a law in the books right now that says if your employer gives you insurance, you cannot buy into another insurance.
That's the difference between the Affordable Care Act and this public option.
Yeah. Employees can go back and forth between employer-provided insurance and the public option, whichever one you think would be better for you. And so just to be clear, This one is single payer. Does everybody understand what single payer is? Okay, single payer means that the doctor does whatever he does, the hospital, whatever. They send the bill to a single entity. That entity pays them. It's like what Medicare is now. You go to the doctor, they send them the bill, they pay it, it's done.
There's no middleman there
There's
of the
no,
insurance
there's
company.
no middleman.
And when they replace this, your private insurance or your employer-sponsored insurance, what are you losing? Is there any policy out there right now that is better than receiving care for any medically necessary thing you need? Is there a policy that's better than that? How can it be better than that? So when these are more scare tactics that they use. Oh, I'm gonna lose my employee-sponsored insurance. So what? You're gaining.
Okay, so, this is another one of the questions that we asked. Where are we with the Affordable Care Act? So I think everybody's heard about the lawsuit that currently it's in Texas, and it seeks to overturn the entire Affordable Care Act. Which of the following statements is true? So the Texas court has said, let's send it to the Supreme Court, which they have decided to wait until after the election to hear it in the Supreme Court. Okay, the Trump administration supports the lawsuit and argues that nearly all of the Affordable Care Act, including protections for people with pre-existing, should be overturned. Or number two, the Trump administration supports the lawsuit, but would retain all protections for people with pre-existing
Before you give
conditions.
the answer. So who says number one? Who says number two? Mixed group.
Number one, the Trump administration argues that nearly all of the ACA should be overturned because the individual mandate is no longer constitutional, and that the ACA's protections for people with pre-existing conditions should be struck down along with the individual mandate. So, in the spirit of being very nonpartisan, and we wanted to say that up front and I forgot, we have three different choices. Expand the Affordable Care Act and create a public option.
So this is under Joe Biden. This is what he's proposing.
Then Bernie create a single payer Medicare for all. And then Donald Trump has repealed the ACA, including pre-existing conditions. Reduce federal Medicare and Medicaid spending. And there's no formal replacement plan. I looked everywhere to try and to put something on this side that would say he had a plan. So who benefits under ACA and the public option? Okay, so some people, but mainly the insurance companies are benefiting. Many of those who cannot afford the premiums or deductibles are literally dying. So 68,000 people died of things they didn't have to die from if they would have had medical attention. That was last year. And 66% of bankruptcies are due to health expenses. And because no matter which study you read, you can go from 200,000 to 700,000 and everything in between, depending on the year the study was done. I just wanted to put up the 66% of bankruptcies are due to health expenses because there shouldn't be any in the United States. This is the United States. Nobody should lose their homes or have to go bankrupt. So who benefits under the new improved single payer Medicare for all?
So did you guys write down? What's your word? Give me a word.
What?
Who's going to benefit under single payer Medicare for all?
Insurance companies.
Insurance companies? Anybody else got anything?
The people.
Pharmacy,
Employers, patients.
employers, patients.
Doctors, everybody.
Oh, for Medicare.
Yeah.
What?
Under Medicare for all,
Oh, Medicare for all, everybody.
You guys were answering the last question.
Yeah.
Okay, forward it.
Yeah, Medicare for all, everybody.
Everybody,
Everybody.
okay.
Yeah.
including the employers.
You
Yeah.
are
Like
so
$28,000
smart.
a year per.
Gotta
You're
pay
really smart.
attention.
Clarification on that one though, because Medicare doesn't pay our doctors much.
All right, we need to, this is a long presentation,
Yeah.
and so you can keep all your comments, we welcome them, but we need to do it at the end.
And we want to hear them,
Yeah,
we really do.
we're not trying to cut you off, but it's a long presentation, so just write them down and hold them.
Yes, please write them down so you don't forget. So everyone, you were right. So union workers, Medicare recipients, employers, those inadequately insured, those who have no health insurance, the sick, the healthy, the old, the young, and those in between. So everybody. Single payer covers everyone for all essential healthcare services. Primary, preventive, and emergency care, mental health, addiction treatment, prescription drugs, medical devices, dental, vision, hearing, long-term care, both home-based and institutionally. So, wow.
Wow! Now, do you guys have a policy that covers all those things?
So Medicare for all is the gold standard.
You got long-term care on your health insurance right now?
No.
So, that, you probably have a supplemental policy for that. But anyway, what's happening
The
here?
thing that we,
Anyway, before we move
oh,
on.
okay.
So we have lots of plans out there right now. We have 7 in the House, we've got 7 plans in the Senate. We've got Bernie's bill, we've got JFL's bill, we've got what other people are saying that they might do. But there's one that is the gold standard, and that's JFL's bill in the House at 1384. So we're saying, wow, why all this turmoil that's going on and why all this disinformation?
So really, it's about, it is about a fear factor, because it is really an amazing bill. And based on all of the other countries that are already doing it, it's very hard to understand why the United States, we are the United States, we could do this. But it is a fear factor. So the biggest fear of changing from a present system, fear of the unknown, and will I lose? I mean, everybody's telling me I'm gonna lose something.
Yeah, but I'm
So-
afraid. What if? They take away my Medicare. What if my employer-based insurance is taken away? What if my freedom of choice? So there's a lot of what ifs out there, probably right in this room, because you're hearing it so much on the media everywhere. You do it, because we're jumping around.
Yeah. So the question is, I have insurance through my employer, why would I wanna change? That seems to be big in all the debates as well.
Save money.
They say that 150 million people will be kicked off their insurance.
So my union, I belong to a union, and my union fought for these benefits, and they are great. I do have the gold standard. But remember last summer when GM went on strike? What was one of the main issues they were looking at was their health care. That's what's in negotiation. So just because the union has really good insurance for you right now, that's not forever. They have to, in the next contract, they're going to have to negotiate again. That's going to affect your pay. And what's the biggest thing? They have strikes and concession bargaining, lockouts, and everyone is trading. If you're getting insurance, then you're trading part of what your salary would be to pay for that insurance. Just because you have it this year doesn't mean you're gonna have it next year. So I retired from Genesee County. I have this wonderful gold plan. However, they're running into problems because the tax base is going down. Insurance is soaring. They only get so much money. They have mandated programs they have to do. So they're at a rock and a hard spot right now. They can either go bankrupt, and then I really will lose my insurance, or they can negotiate our contract. So in all likelihood, I'm probably gonna have some kind of health insurance, but it's not gonna be the gold standard anymore. They can't afford the gold standard anymore. So even though I retired with a contract with a gold standard insurance, they are now trying to figure out what they're gonna do. So I'm either gonna have higher premiums, higher deductibles, higher out-of-pocket costs. So don't be sitting back thinking, I'm set for life. That's not the case. Every year, employers have to find a new plan, they have to search, just like she was before. They don't have control over what the insurance costs. So they're searching for what is best for them that they can afford and their employees. My husband retired from GM, had a wonderful retirement package with insurance for life for me and him. But you remember when GM almost went under? What did they get rid of? Their health insurance for their retirees. So again, we have two cases in our family where we had wonderful insurance, but that changed. I'm gonna have a lesser one. Jim lost his.
With single-payer Medicare for all, you don't have to worry about your employer taking away or changing your insurance during union negotiations. You have guaranteed health care for life, regardless of whether you change jobs, get sick, lose your job, want to start your own business, move, retire, get divorced, or your company goes out of business. So here's another one of our myths. Medicare for all takes away your choice.
So you answered that on your questionnaire, did you? Did anybody get to that? Which would you prefer to have? You want, raise your hands. Do you want a choice of doctors and hospitals? Or do you want to be able to choose which insurance plan you have?
I want both.
If you have an insurance plan already that covers everything,
Yeah.
how many choices do you need?
Oh, that's true.
Okay, so your choices. Your choices. If you're eligible for Medicare and choose an Advantage plan. So Advantage plans are Medicare with private insurance, run by private insurance.
How many people have Advantage in here? Okay.
Okay. It's administered by many for-profit insurance companies. They change yearly, you know that. They have various options, ranging from coverage, premiums, co-payments, deductibles. They come with restrictive networks of providers.
Wait a minute. I'm an Advantage member. I may be losing my insurance. So Jim and I, you know all the places they're going and you can talk to these agents, and we went to one. This is what I brought home.
Blue Cross Blue Shield.
That's my tax dollars at work. That's my healthcare dollars at work. Talk about complex. In Maricopa County, you have the choice of 41 different plans. They all have different fees to them. So compare that to Medicare for all. I did get something though. I got this really nice bag.
I got one of those.
So when we talk about being complex and having a lot of overhead with administration, I mean, today you even have to have this middleman to help you understand all the different plans that are out there.
That's right. And 34% of the premiums go to administration. So under Medicare for All, it's administered by one government agency, like we were saying, one single payer. It's stable, everyone is covered from birth to death for all essential healthcare, no copays, deductibles, supplemental plans, surprise medical bills, or networks. When Carol comes, she has her Advantage in Michigan. When she comes to Arizona, her healthcare plan is Prayer.
So if you
The
have
networks in Michigan.
If you have an Advantage program, it's good for a certain area. Now, if we come out here and have a heart attack, it takes care of it. However, I have fee problems, so I'm paying my doctor. So there's a lot of advantages to Advantage programs, but there's a lot of disadvantages that you don't think about until you actually have to use it. So under Medicare for All, that's good across the United States. It doesn't matter where you're at. If you need health care, you can go. And 2.3% of the healthcare dollar goes for administration. In Medicare, you know how we're saying, okay, they chose to call it Medicare for All because Medicare is a beloved program. But the part that they're going to be using is the structure. That machine that's been working for 54 years, taking in 10,000 people a day. I mean, this is a structure that works. You don't have to create anything new. And they've got their administration down to 2.3%. So choice, who makes it? Now this is what we were just talking about. Your insurance is provided, if it's provided by your employer. So employer-based plan
Your employer chooses your health plan. Your insurance chooses your healthcare provider network. The insurer chooses what prescriptions, treatment, and procedures that will get covered. And your insurer chooses your doctors.
So where's your choice? You're giving away your choice.
Under Medicare for All, it's very simple. You're free to choose your healthcare provider and your hospital, and everything's covered, crosses state lines, and there's absolutely zero networks, which is exciting to me because we love to travel. So at least with traditional Medicare, I can travel throughout the country, and there's no networks. I can go and see a doctor wherever we travel.
I saw this one joke for state-based. Some of the states are trying to pass their own Medicare programs. They'd be good in-state. And so it's like somebody would come out to Arizona and you have to have a colonoscopy, but your doctor's in Michigan. And so I had a husband and a wife, and he's laying on the table, and he said, honey, get the flashlight and the movie camera.
Okay, how can we possibly transition, this is a question people have, from our current system to a brand new universal single-payer system? It seems impossible. Maybe we better just take incremental steps, but we've taken incremental steps since 1965, and it just hasn't worked.
But you hear that argument over and over. If we would just take an incremental step, I think that's what we need to do. We've been doing this for 54 years. We've taken incremental steps. How many more incremental steps do we need to take? And what happens by taking another incremental step? That'll be another 10 years. And what happens?
So several incremental steps have been taken. There we go. Since we just told you this. Millions of people are still left uninsured, though, with an incremental step, and underinsured. People will continue to die because of this, and escalating administrative costs continue. Remember that's why I said, remember this slide, where the United States is going straight up, where all the other countries are staying pretty smooth. The escalating costs continue. Even after, if we were to look at that slide again, in 2010, when we did the Affordable Care Act, it was supposed to level off the healthcare costs, but if we looked at the graph again, you'd see it continued to rise. And I guess the point is, when you have the insurance companies involved, of course it has to, because they still have to make their profits.
Profit, that's the word, is profit.
So if not now, when? And we are not creating a brand new system. We just said that we're building on the 54-year-old existing system. It'll just be expanded to everybody. And everybody knows nothing's perfect. That's why they say enhanced. Enhance Medicare. Expand Medicare. Saving money while expanding, and here's our comparison again. 2.3% of the budget for Medicare, and insurance has a 34% overhead.
So think about that as your healthcare dollar. For every dollar that you're spending, you can either give 2 cents or you can give 34 cents to the insurance company for their profits.
So transition is possible, and like Carol was saying, there's already a bill in the Senate and a bill in the House, and these bills have been researched for years to show in detail how this plan can work. And in the case of the 1834, since 2003. The payment and provider structures already exist within the Medicare system to permit a transition to a single-payer healthcare system. And then I think I told you this, they implemented Medicare in the 1960s, 1965, in 1 year without computers.
That's amazing.
Yeah. 10,000 people join Medicare every day.
Wow.
Improved Medicare for All is simple, and this is one of my favorite little slides. So, point up there to single payer. Single payer is, it's one entity, and it's responsible for paying our medical bills. Thanks, Carol. So this is this little guy here. Individual medical expense, single payer. You're making this way too hard, the little boy says. And here's the multi-payer chaotic system that we have right now. Public option, taxes, individual medical expense, insurance companies, big employers, state plans, Medicaid, all over here. So important medical decisions are left up to the healthcare provider and the patient. I know we've said that over and over again, but it's so important. You go to your doctor, he tells you what you need, you do it, you get, and the bill goes to that single payer. Private companies make decisions about our healthcare based on their bottom line, not our medical necessity.
So do you kind of get that?
Mm-hmm.
So this is single payer, one place. This is multiplayer. You're sending it to all those different insurance companies, and they have to decide whether or not you're gonna do it. And then if they say no, that you're denied, then you have to reapply again. And so it's a maze that you have to go through with multi-payer. So that's what multi-payer means. It's going to many, many different sources.
So what happens to all the insurance workers? And that's another big question people have. Well, what's gonna happen to all these people that are working right now? But both of the bills have allocated money for 5 years to help people make transitions. And new studies are coming out that are saying there's going to be so many more new jobs, than jobs that are lost, because those people that are doing all that administration now, many of them who have degrees in healthcare, will now be able to do what they were trained to do, be nurses, be healthcare professionals, so that one just isn't true. There's gonna be plenty of jobs for the for the administration, and 5 years of money to help them make that transition through education, whatever they need. So the biggest question of all, how do we pay for it? All of the plans cost the government, you, the taxpayer, more. They all cost money. Well, but here's the thing, we're already paying for it. When you think about it, we are already paying for it. The government already pays for 2/3 of healthcare. We're already a single payer system for 2/3 of our healthcare costs. And I want to show you a visual on this. So we have,
If you look under the current spending in the United States already, you got your tax dollars that are going for Medicare, Medicaid, veterans, TRICARE, CHIP, government employees, Congress, the president, and subsidizing the Affordable Care Act. These are already coming out of the budget, and what they will do is simply go into the fund that will be funding the Medicare for All system. It's a trust.
You're
So-
missing Native American health care in that list.
You're right. You're right.
Most of the tribes pay for their own.
yep.
But they go through that public option.
Oh, good, thank you, Bonnie, we'll have to add that.
They're not in the present bills for Medicare for All. They've chose not to.
They chose not to because they don't want to be associated.
They don't trust the government.
I wonder why.
So out of a household, like on the other side of your sheet, the kind of things that you probably don't even think that you're paying right now, out of pocket, your premiums, co-pays, deductibles, supplemental insurance, vision, dental, hearing aid, etc.
So that's all the other third. That's 1/3 of our costs for our healthcare. So what they're going to do is, they're going to take all of the existing money that's already in the budget, and they're going to get new public dollars, and there's a whole bunch of different ways. One is repealing the tax breaks for corporations, but there's so many of them that replace what you already pay here in your household.
So with these plans that have been proposed, everybody gets health care and overall spending is lower. And 95% of the people will be paying less under that because you're getting rid of your deductibles, your co-pays, all those kind of things. And so then, they complain that taxes might be raised, but when you balance the pros and the cons there, you're actually gonna be saving money.
And another current study, just out in February 25th, was a Yale study that says Medicare for All would save the U.S. $450 billion while preventing 68,000 deaths a year. 29 studies, the savings would fund full coverage. Now, out of those 29 studies, so 86% of them said that there would be savings from Medicare for All right up till, and only a couple of them said there might be some expense in the first year. But all the rest of them said that there would be, money would be made, or saved, I should say, by going for Medicare for All. 253 economists, the time is now for Medicare for All.
You probably haven't even heard these, have you? Because they're not on the national news.
So again, how do we pay for it? I mean, now we've had all these studies that we can trust that say it can be done, and it can save money, and it will save lives, but we still want more proof. So how do we pay for it? $600 billion in savings would come from negotiated prices on drugs, medical equipment, and services. Here's again, our lower administrative costs. That's a big one. Only one agency is processing and paying the claims, and profit is eliminated.
You gotta speed it up.
Example of savings in hospitals. Okay, 900,000 hospital beds, 900,000 staff to deal with insurance and billing. The average hospital can't put a doctor and a nurse at the end of each bed because they have an insurance person that they're paying for.
Are you aware of that? That for every hospital patient, there's someone in the billing department?
Yes,
Okay.
For every,
and the one over here, they follow you around.
But you don't
Literally.
have a doctor there all the
Literally.
time. Yeah. Okay.
Okay. Healthcare dollars go for healthcare, not administration. Did I miss something?
no, I just missed
Okay.
this.
Why haven't we heard about this? And this is why we all have all these doubts and fears. There's an alliance of health insurance and drug companies, hospitals, and equipment manufacturers. And they were formed just a year and a half ago when they realized that Medicare for All was really going to be a threat, to kill it. Do whatever they could to create fear, uncertainty, and doubt. They've called it FUD. That's their acronym for what their strategy and plan is. Create fear, uncertainty, and doubt in the public about Medicare for All. So let's tell them they won't have any choice. Let's tell them that they're going to get their insurance taken away from them. Strategy, part of the strategy is to give allies fear-laden talking points to divide people and hide an agenda designed to enrich powerful corporations, and utilize the media to spread the information, because there's a lot of media can't afford their reporters, so they have to rely on lobbyists and articles that are sent to them. And
But the question is, why isn't anybody asking about what is the cost of doing nothing? We hear all these things, oh my gosh, if you have Medicare for All, it's gonna cost $1 billion and $1 trillion and all these kind of things. What about all the other plans? How come we're not hearing what they're gonna cost? Why are we not hearing what is the cost of doing nothing? It's all going to be going up.
so focusing on only the cost of doing something about these problems without mentioning the cost of doing nothing is misleading, because that's a much bigger number. How did the other proposed plans deal with the cost of adding more people? Carol said that the status quo current system is not sustainable, and we said that right off the bat. Prices are raising uncontrollably every year. It's estimated that the cost of healthcare will be $6 trillion by 2027. If we can afford $3.65 trillion right now, how can we afford $6 trillion in just 7 more years? So that's the cost of doing nothing. You see, they tell you the cost of what'll happen if we try and make a change, but not what the cost is if we don't do anything.
We have 4 minutes.
Unaffordable, it will cause massive new taxes and inflation.
Higher taxes may be needed, but on whom?
So this is just one of the ways that they're proposing they pay for these proposals.
So that the Tax Cuts and Jobs Act that was enacted in 2017, repeal that. And it's funny, they say, what is it gonna cost if we do this health insurance? But they don't say, okay, we're gonna give all these tax breaks, and they don't say, where's that money coming from? So why are the tax breaks more important than the health care?
Billionaires paid less than the rest of the population.
So Amazon, as probably you've heard by now, in 2018 made $11.2 billion and paid 0 in federal taxes. So isn't that ridiculous? You and I are paying taxes, but these gazillionaires are not. So the system has to be changed there.
And this is just one. I mean, all of the rest of them followed right in line. All the other big corporations.
Facebook and
Yeah, Google and all of them. When we all pay their fair share, everyone will benefit.
oh, yes, but it's really socialized medicine. We don't want socialized medicine.
Single-payer national health program is not socialized medicine. The definition of socialized medicine is the government owns the hospitals and the doctors are paid by the government. So that would be, out of those 19 countries, UK is the only one that does that. All the other ones have figured it out based on their own values on how to provide universal healthcare for everybody, and they've all done it different. Every single one of the 18 has done it differently, but they've covered everybody. UK is a truly socialized system. And guess what? The VA is a socialized system within our country.
You know, when we talk about having our tax dollars go for infrastructure or the military or the fire department or the libraries or the police, nobody goes, oh my God, those are socialized programs. I'm against that. So why are we labeling this as a negative in the first place? It's just one of those words that's a scare tactic.
So why isn't this policy already? And again, we're going back to them. You're saying, well, why? You know, if they're saying that they're going, this organization is going to create this FUD, how are they doing it? Well, through the billions of dollars that they're going to spend on, actually, this is not partisan. This is non-partisan problem. Bribery.
They're both being bought off.
They're both being bought off to say what the healthcare industry wants them to say,
What happened?
or the insurance industry.
Oh.
And here probably is one of the most visual of all the slides, where your healthcare dollar is also going. And of course, this is just 6. There's so many more.
So, you know, it's hard to say, well, this guy's making 83.2. What is 83.2? I have no concept of what 83.2 is. But he's making $228,000 a day. I can kind of relate to that.
And down here is how much the average wage of the salary were $44,980.
So this was 2017, so you know they're higher now than they were then. So why do we have insurance companies? To make healthcare affordable, right? Isn't that their goal? They're terrible at it. So you are paying them to take away your choice of doctors, hospitals. I think we need to let the insurance companies stick to other things like auto insurance, home insurance, warranty insurance. We don't need to have our healthcare dollars going for profit.
We do have a choice, even though the for-profit healthcare industry is telling us we don't. We do have a choice. So we are already paying for it. We've realized that we are already paying for it through our taxes or through all of our premiums, co-pays. So there's one question left. Do you want to give your healthcare dollars to insurance companies, CEOs, shareholders, bureaucracy, political donations, lobbying, TV ads, profit, or do you want your healthcare dollars to go for healthcare for you, your family, and for everyone?
But as Aaron Brockovich says, Superman's not coming. So if we want our problems fixed, it's going to be up to you and me. And so what can each of us do? Share facts with family and friends. They're getting all the disinformation every day on the TV.
And we know that Carol and I are doing probably a little bit more than a lot of you would like to do.
Do you think?
But this would be something so simple to do, to share the facts. Carol's got an amazingly fabulous trifold and handout with a lot of the key things that you could pass along.
And we have a lending library, so you can get these documentaries that are excellent online, but we also have hard copies if you'd like to borrow them. We have a
So you
lending
can have a
library.
house party, invite some people over. These movies are, documentaries are amazing. Or demand our elected officials pass single payer, improved Medicare for all, every chance you get.
So help by educating, advocating, and if not you, who's gonna do this?
All of us need to do this.
Now, the last segment is Colleen, who's going to give you personal experiences.
Well, I think we have to thank Carol and Linda. Are you hearing me now? That was an excellent presentation. It's not only 100% true what they said, it's 125% true. Let me give you my background on healthcare. I first started as I've been in it for about 40 years. I started out as a nurse 40 years ago, actually. Joined the Air Force, had three and a half years active duty. Got out, they sent me back to school. I went back to school, got a master's. Worked actually in, just in regular hospitals, private hospitals downtown. So is this, okay.
Talk real close like this.
Private
You
hospitals.
just have to have it by your mouth.
Oh, right in front. And
You
push
really
this
have,
down.
you really have to go like this.
Eat it like an ice cream cone.
Oh, there it is. Okay.
What are those?
Worked actually downtown in private hospitals while I was getting my master's. Then got called back to active duty for Desert Shield, Desert Storm. It's still not coming?
I think
Battery's probably dying.
You wanna switch your,
Go like this.
and talked into it.
Okay. Sorry about that, folks.
there, much better.
Actually got called back to active duty for Desert Shield, Desert Storm for about a year. Learned about nurse practitioners because I ran actually a
Hold
primary
your
care
other hand
clinic
when
for
you
them. We had a lot of we only had a couple docs, but mainly NPs, couple PAs at the time. Got off active duty, and then the next day had to go back, had to find a job, because guess what? I had a family and had to provide for the healthcare for my family within 24 hours. Especially working in the field, you know the costs, okay? So that's how I ended up at the VA. Ended up working for the VA for about 10 years. They sent me back to school to become a geriatric nurse practitioner. So while I was there, I actually worked for, started out in their long-term care as a charge nurse, went to the community health, so I had experience in that for like 2 years. Went out and actually into the communities and certified assisted livings and nursing homes, okay? Then went back to school, got the NP as a geriatric nurse practitioner because I wasn't interested in kids or pediatrics at all and didn't want to do GYN at the time. So long-term care was a good option for me. Stayed with them for probably about 5 or 6 years. And actually it was 3 nurse practitioners that actually ran. We probably had a 100-bed facility, 50 beds on each of the units. We did have 1.5 physicians that we collaborated with or worked for. And they oversaw us, but it was actually the NPs that actually did the day-to-day functioning. Left that and then went into the private industry again, back to a company called United Healthcare, which I'm sure a lot of you are familiar with. Ended up working for a company called Evercare in long-term care. And again, I probably roved between 8 different facilities, nursing home facilities. It was funded through United Healthcare, and just as a point of fact, when she brought up the CEO salary, this was probably about 20 years ago. He was only making $7 million then. Now he's currently making $23 million. So you can see part of the problem right there. Enjoyed working that. Again, I worked with the physician. It was the NPs that probably did the primary care, but we always had docs to refer to. And then left that after 10 years and ended up working in a local, large, what we call a CCRC, which is a retirement community, serviced over 650 people. I actually ran a health and wellness program. However, the last probably 5 years, all I did was troubleshoot insurance problems, pretty much for my elderly residents. There were some days that I never touched anybody under, I'd say 86 or 88. Because what we have growing right now is we have a growing senior population. We have the centurions, which are over 100. We're retiring I think it's 60,000 of the baby boomers every day now are retiring, okay? I'm one of the youngest baby boomers. I'm only 62 and a half. I have a husband that's 10 years older, okay? So he's one of the older ones that have been retired for a while. So that's when I really got into the insurances, probably more the last 10 years. Because guess what? I had to get your insurance for you guys. I had to figure out how you could access your insurance and get the care that you needed. The one big thing that we always want to avoid as providers is we want to keep you out of those emergency rooms. We want to keep you out of those hospitals. Not only because of the costs, but it's the best thing to do. Oops, I think I turned it off again. Okay. It's the best thing to do for everybody. The patient gets the high quality care at the lowest level of care, which is way down here with primary care. Primary care is becoming a real big problem with the access to care, because guess what? We don't have enough primary care doctors, okay? The NPs and the PAs are stepping up and filling that void. Like I said, we closely collaborate, and we can do the stable chronic people. But again, when we send you out to those emergency rooms, you get your prescriptions, your drugs changed, as well as the high costs. And when you get back into your own house, your own little independent apartment or your assisted living, that can create big problems. And you get repeat backs either to the emergency room or to the hospitals, okay? But the big thing that we have coming down the pike is we not only have the older population that's coming down, we have a tsunami of diabetics, of obesity. We also have a tsunami of dementia that's coming. And what dementia ends up coming or dealing with is actually in the long-term care setting, which again is not covered. It's one of the big ones. And you're looking at maybe 10,000 or more a month paying for placement. The other big number that you have to remember with dementia is 1 out of 2 over age 85 will go on to develop dementia. So that's an astronomical number that is, and you're shaking your head because you see it. I can tell you that I worked with them for the last the last 20 years. They say females are at a higher rate than males, but I saw couples, which was kind of unusual. But again, they ate the same food, lived in the same household, had the same amount of air pollution or whatever, toxic chemicals exposures. 1 out of the 2, it didn't matter. In half the couples, it was probably the females, and the other half, it was the males that developed it. The average life expectancy for somebody with dementia, anybody have any ideas?
Yeah, 86.
It's actually about 9 years. The one that everybody associates it with is our former president, Ronald Reagan. And he actually had signs and symptoms of it in the last year or 2 of his presidency. And then she very gracefully took care of him for the next, I think he lived maybe 10 years after that. So the other 2 things, what both Carol and Linda referred to through it all, is the Medicare for All, or actually as providers, from the provider side, we call it Physicians for a National Health Program. Same thing, it's a one-payer system. We actually all want it. And if you actually, well, I shouldn't say all, but I should say the young physicians, the young providers that are coming out right now want it because it simplifies our lives so much. In an average 40-hour week, when I actually was working, a full day was devoted to nothing but paperwork. It was being on the phone, doing prior auths, staying extra hours, the extra 60 minutes or the 90 hours or whatever. The other reason why providers want it is you actually take back the healthcare, the art and science of healthcare from the insurance providers and give it back to the people that were trained to do it, especially the physicians. And now, like I said, there's not enough of them to go around in the primary care setting. Unfortunately, a lot of our physicians do go into specialty practice because guess what? They're higher paid. There is some solutions or some things that they're working on for that, but it still may take a while. And those will create more jobs. With the single payer system, definitely it will create more jobs in all aspects of the healthcare system for the people that don't have it. So the other thing that I wanted to mention that I thought was really interesting, and this just happened since Friday. I went to the local Walgreens to pick up my husband's prescription, and I was in line. I was number 6. There were 2 people up in front, behind the counter, they're actually pharmacy techs that give you the scripts and that. The one guy was up there. He was obviously creating the issue for the rest of us, and I made some comment to the man next to me because it was so slow. They actually had to call back the manager from the front of the store to come back and help process the people in line. So the man next to me speaks up and says, yeah, this current healthcare system that we have. He said, I went out to my provider and it was for an injury in his lower leg, and he thought the provider actually said he had a muscle tear, whatever. He wanted him to get an MRI. And he actually told him that his insurance company would probably deny it, and he did try. It was based on, this was what the provider was actually telling him, that it wouldn't go through. He said, but you can go to this building, this radiology center, and for $270, they will do the MRI. I'll get the report within 24 hours, and we can go from there. So that's what he did. He went to the radiology imaging center that he was sent to, asked the cost, $270 for cash, and then he also asked him what would be the cost if it was charged to his insurance. He did have insurance. Came back at, take a guess, what they were going to charge his insurance at. $2,200. So of course he paid out of pocket the $270 so that he could get the care that he needed. And that probably about 7 or 8 years ago, and I've done that too, where the imaging centers are, because your insurance either won't pay or it's astronomically so much higher, 300, 200, 300% over and above, have sent people there. There's advantages and disadvantages. Yes, it's cheaper to pay cash, but again, how many times can you pay cash, okay? Versus paying the $2,200 up front and then having it applied to your deductible. Right now, these deductibles are huge. They're $5,000, they're $8,000, $10,000, so you always have to look at the cost and the benefit in making that decision. If you have Medicare for all or a one-payer system, that really goes away. As a provider, all I want to do when I see patients is, I want to see that for a young person, for a 14-year-old if she has asthma. What I want to do is fix the problem. I want to get her on the medication, I want to diagnose it, I want to get her on the stable medication, and I want to teach her about her disease process and hopefully keep her out of the emergency room. Whether or not she has, the systems that I've been in, I don't deal so much with the insurance part of it, or hadn't, because it was taken care of behind the scenes by all these admin people that they were talking about. That's my goal as a provider, okay? Again, I want to take care of that 55-year-old female that I picked up that had breast cancer, okay? I want to treat her at a stage 1, because guess what? I can get her in, I can diagnose it, I can get her in, I can get her the treatment she needs, and get her on her way. Instead of that lady waiting for maybe 6 or 12 months because she has fears, she doesn't have insurance, or she has such a high premium and such a high deductible, she waits till she's a stage 3 or stage 4. By that time, it's metastasized, okay? Which means it's spread, either to the brain or to the bone, and then she's gonna fall. She's gonna go into the hospital anyhow. She's gonna create this huge 100 or 120,000 bill, and will have a much shortened life expectancy than instead, if we had, again, Medicare for all, I could have gotten her back, okay? Probably within maybe 2 months or 3 months. She could have gotten back to work, and guess what? She'd have paid her state, federal, county, city taxes, and she'd have had maybe another 10 years of all that. So that's what you really have to think about when We have the no insurance and the underinsured too. And when I told you about that $2,200 bill, what I forgot to mention is, even if you do have insurance, guess what? You're paying for all of the underinsured and the no insurance patients anyhow. That's what that $2,200 versus the $250 bill paid for. That's been going on for years, okay? Just deliberately for years. Let me talk to you about two case presentations. Usually that's the way that we present them. So I'm going to talk to you about Jeff. Jeff is 60 years old. He's a construction worker, was a concrete layer. Kind of drifted in and out during the years, but he paid all his city federal taxes, right? All of a sudden at age probably 58 and a half, he started having problems with dizziness, got diagnosed with blood pressure issues. Of course, he's working outside here in the heat. So had a couple instances where he had to go into the emergency room. Didn't have insurance, was lucky enough he had a female companion, quickly got him on access, right? And again, if she wasn't there, that admin girl would have stepped up and got him on access. What they found out, eventually after they kept him for about 5 days, again, on our state dollars that we're all subsidizing and paying for anyhow, he got diagnosed with, they thought, kidney disease, because one of his kidneys was atrophied and small. So they set him up for surgery, took it out, said, oh, you got to go down to the University of Arizona Hospital down in Tucson. Never quite made it there. Some of his lab tests came back, but the long and short is he's what's called, he has chronic kidney disease. There's 5 stages of it, and he's probably between a 3.5 and a 4. He's a high candidate to go on dialysis, probably in the next 2 to 3 years, okay? So we're gonna pay for him one way or another. We might just as well pay for it up front. And again, right now, he is, his primary care provider is actually his kidney doctor, his nephrologist. Initially after he had the surgery and all that, his kidney function was way, way down, just close to dialysis, okay? With the care that he got through Access and his physician, he's at least up to 27, 28% kidney function, and we're hoping to keep him there. He also was able to get back to work. Granted, he can no longer be a construction worker out in the heat. He is actually working at a local Ace Hardware store. But what happened is, and he started out at 28 hours, I think, maybe 24, 28 hours of work, not your usual 40 hours of work. So with his Access, he's only allowed to make $1,421. So this last December, or maybe it was November, whenever we had 3 pay periods, it bumped him up, made too much money. Guess what? They caught him like that, knocked him off. So this, again, is a high dollar patient that got knocked off because he made maybe 50 or $100 off his healthcare system. So he asked me what he should do. My best, if I had any options or any suggestions for him, I'm like, you know what? Go back into your HR person, tell them you don't want to work the 40 hours. You don't want to work the 35 hours. You want to work the 29 or the 30 hours in order to keep your health care. Because it would have been astronomical for him. He had a pre-existing condition, okay? So actually, I don't know. I mean, I'm assuming that's kind of what he did, but that was the only suggestion that I had.
You're gonna have to speed it up.
Okay, so let's see. That's kind of our broken health. It is a very broken healthcare system. So definitely this is the way to go with Medicare for all, or a one-party, one-payer system. It'll be a simplified system for us because all you'll have is a provider and you'll have an assistant, whether it's a nurse or whether it's just a CNA. And they'll ask you your name and your last 4 of your social security or your medical ID number, and that's it. The current system is unsustainable, make no doubt about it. And now, I will mention the coronavirus. If you think we're up to close to 19% of the gross national product, in a year or 18 months from now, we will probably be 20 or 21%. How do we compete in the global market then? So if this doesn't push us, it's a health concern now, Economically, it's a big concern too in the future. And like I said, remember those tsunamis that are coming down the wave in the next probably 10 years. The other thing that I did want to mention is about 30 years ago, if we fail to learn from history, we're doomed to repeat the mistakes. 30 years ago, Hillary Clinton tried to get a national health bill passed. She was a female. She sat down at this table. I read her health care plan book. And the thing that amazed me then is there were no females, no ethnic minorities at that time. She got taken down by the good old boys' school. Nothing against the men here, but there was not a single other ethnic minority or a female, okay? This was a well-educated lawyer that had brought Arkansas, between her and her husband, brought them out of the deep end with education. She knew what she was doing with healthcare. That was 30 years ago. We failed since then. And in the meantime, the costs are just astronomical. And it's only going to increase. And like I said, with the coronavirus, and also don't believe that your costs, if you're currently on Medicare, they will go up. They are not going down because of those private insurance. The pharmaceutical company has us by the tail, and they're not going to give it up any way, shape, or form. So, okay, so we're going to take questions, or?
Well, it's 5 to 2. Just, I would limit, but yes, take some questions, but they'll have to be limited.
All right. Gordon?
On your scale of expenses, were you providing us with, you said government, and I'm not sure what you meant by that. Because you can't, from my perspective, have healthcare and rule the world and colonize at the same time. Look at the money that we spend on armament. Check, that whole process, and look at who the lobbyists are. Didn't bring that up either. So I appreciate your lecture, but where are we going if we can't control? Because all the other countries in the world that have health care are not trying to rule the world. Their allocation is to health care, not to armament.
Well, any of the plans are gonna cost money, whether we stay the way we
I
are, all
agree
that.
with you.
The one thing about this is because you're getting rid of that middleman, you're saving money. The other plans don't save money. They're adding more people to it, which is going to increase how much our government is spending for it. And you're not building in the savings of that. Go ahead.
This is kind of a little rah-rah from Canada. I was born in the States, but after grad school, I married someone and moved to Ontario, Canada. I can only speak for one province. I have a healthcare card. When I was teaching, my healthcare was paid for by my employer, but now I pay $150 a month as my premiums. That includes dental. I get my teeth cleaned professionally 3 times a year. That's the kind of the extent of my regular dental.
And you're overall happy with it?
Yeah, and I'm very happy with it, but when I turn on the TV and see somebody saying, oh, well, Mr. Sanders, who would you give this care to? Would you give it to the undocumented aliens? Yes. There's your FUD thing is perfect. I also realize I pay higher taxes than probably many of you would have done, but when I was teaching, my last salary was $87,000 a year, and I'm sure I wouldn't get that with, even with a master's degree here in Arizona. So, I just have a philosophy that, okay, there'll always be a few people that built the system, that know they can have health care, so amputate my right toe, it's stupid. But you have to, provide for everybody, and philosophically I just do that. But I have a brother who always says, oh, my premiums went up, and I'm sure they did. What about all those welfare people and all those Mexicans that, you know, we're paying for all of them, and that's why we have to have more teachers in the school because they don't speak English. I mean, it's just.
Here's the answer to that. You either pay on the front end or you pay on the rear end. If you pay on the rear end, it's gonna cost you more in the long run, okay?
Yeah.
Granted, it's not the average person, okay? It's maybe 8-9%. I don't care. We still need to cover the majority of our people. This is the United States of America. We are not a third world country.
I think what she's trying to say, the front end or the back end, is like, if you need something now, like kidney disease, taking care of it
Right.
immediately, it's cheaper than letting it go to then you're on dialysis. Dialysis is so expensive, and you wouldn't have needed to do that if you would have treated them in the
But
beginning.
if people don't have any health insurance, they just die of kidney. I
Well,
mean,
that's
they're
the
not
six-
on dialysis,
Yeah, that's the
are they?
63,000 people that die
Yeah.
of complications that they wouldn't have had if they would have had health insurance.
I travel quite a bit, and so every country I go to, I go, tell me about your health system, and what about those taxes? You're paying so much, because in Denmark and all these places, they're going, yeah,
But we
so
get a
what?
lot for our taxes.
I don't have to, who are the happiest people in the world? They don't have to worry about healthcare, they don't have to worry about education, they don't have to worry about their retirement. So it's a whole different mindset, well, you pay one way or the other, it's just how we're educating.
And we have a question here.
Hi, this is mainly from a doctor's perspective, not mine, my daughter's. She's a family practice doctor, and she's moaning and groaning like crazy.
Put the microphone up.
She's moaning and groaning like crazy because they spend a fortune on staffing to handle insurance.
Right.
She realizes that this will save her a lot. Also, primary care doctors do not get paid all that much. So for all the agony they go through, you know, I guess my question is, when I see like my Medicare bill, and what the doctors ask to be paid and what they actually get paid, they get paid peanuts for Medicare. So even if she's not paying for all the ancillary staffing, if they're gonna be paid the same way that Medicare is paying them now,
They won't be though.
they're not gonna be ahead of the game very much. And you need primary care doctors.
Two issues. Right now, it costs so much to go to medical school. The majority of the doctors are going into specialties. That's why we're so short on primary care doctors. And so if that isn't the issue that, gee, I'm so far in debt, I have to be a specialist, we're going to have more primary care doctors, which we need more of. And how that's been set up, you know, we can't say exactly how these are gonna be set up. You know, you're gonna, hopefully you go for the goal plan and everybody's giving input in this, and you're going to develop a program out of this. So we can't say right now, this is exactly, all these other countries have many different forms of healthcare. And none of them may fit the United States, but we create our own solutions to that. And so how it's been set up before is you don't have the higher uppers deciding this, but you have doctors in there. You have a conglomerate of people in a region coming together to set up, okay, what's a fair pay scale? Because it's not the same across the United States.
It's a generalized budget. What they were figuring, the way that I understand it, like in New Zealand and some of the other countries, they get a budget. We're over budgeted now with all of our hospitals.
It's on.
It's fine. We're over budgeted now. Our hospitals, like Carol said, are getting really creative because we've had so many beds. Guess what? We've improved medicine so much, everything's done on as an outpatient. But you still have that hospital with 150, 200 beds. The newest trend now is to build an emergency room with about 50 beds and then maybe 20 beds to hold over. So those CEOs and assistant CEOs are coming up with all these creative ways to charge people, okay? And it's astronomically increasing the cost of them. actually 40 years ago, we had a certificate of need program. And we had to prove that we actually needed the beds way back then. And it was a little bit tougher. Now, they say competition breeds, lower prices? It doesn't in the healthcare industry. That what they do is they actually leapfrog over each other with the higher costs. They've done that. A typical one is the radiology costs, okay? We had x-rays. Now that you have CAT scans, then you had MRIs. The latest is PET scans. A hospital does not need 12 MRIs or 3 PET scans. PET scans can be like $3,000 to $5,000, okay? MRIs, I told you, can be anywhere from 270 to 2,200, okay? We never had that in the military, okay? We had simple straight line stuff. We still gave good care. And it was cost-effective care. We got our people back. But these hospitals are like prima donnas anymore. And a lot of the practices are prima donnas.
Well, I just wanna make sure that doctors do get, and one of the other big concerns too is the amount of time they get to spend with patients. Cause right now it's get in,
It's
get out.
8 minutes.
get in,
It's
get
8
out,
minutes to 11 minutes.
So that they can get paid to cover the staff.
One thing I wanted to add to that was, because I did a lot of research on the doctor piece,
Yeah.
and we had to take the slides up to introduce our talk today. But the doctors are excited about this, because not only do they know that they're going to save the money on the administration, but they're going to be able to see so many more patients, because they don't have to spend all the time in the office with
Well,
the
as
paperwork.
long as they still get paid.
Yeah,
Because
and
if they
then-
get paid, the
They're
doctors.
never not gonna
They're-
get paid. And the other thing is, they can learn from some of the other systems, like the VA system. We have one of the best, I don't wanna say computerized systems. I go anywhere in the United States, all they do is plug in my last name, my last four.
Well, they got all
That
your-
cuts down, right now, patients go to different systems, different hospitals. The one, Honor Health does not talk to Dignity Health, does not talk to Banner Health. So what happens is, as a provider, when you go into a computer and you write a note, it's like 20 pages it prints out. We don't have the time to look at 20 pages. We just want the meat of, and the notes are the same over and over. So they could do something like that with the National Health Plan, which would save probably millions. I'm not a super techie, but again, and eventually we are gonna have little chips, probably in our wrist, that we will carry our critical medical information with us, our allergies and some of the
That'd be really
others.
helpful.
It's already coming in some of the places. Oh, and the latest thing I did want to mention, you don't want to get your primary care. I just read or heard about this. Walmart now is opening up primary, tell your daughter this, I don't know what she'll think. Anyhow, they're opening up primary care clinics. They're attached to the Walmart. They're only hiring physicians. It's down in the state of Florida, in the rural areas, okay? So you can actually go in, they're charging discounted prices, they're trying it out in these two places. They're charging $55 to $100 in, like I said, the state of Georgia. I don't see physicians actually doing that because
Right.
unless they're paid
But
double.
they have them in Walmarts and have a PA or somebody that they hire.
No, Walmart is not hiring PAs and not hiring NPs. They're only hiring MDs.
I have a
Did we have another question?
We need it,
Oh, here we go.
and then we're gonna have to wrap it up.
Will Congress also be in on this plan? I mean, right now they have their own Cadillac, and with our government not taking care of, they don't own the drug companies. So what's to stop them, the doctors, from prescribing those very expensive drugs because the sales rep has just been there? And then the other thing is, what is essential? I don't wanna pay for some politician's tummy tuck or facelift.
No, that's not called essential.
Or transgender. Do we have to get rid of lobbyists?
Yes.
To do this, that's the only way it's gonna happen.
So you guys, we're not saying any of this is easy. I know we maybe made it look like it was really, we're not saying that this is easy. In fact, we're saying this is really, really hard. because we're up against that ad hoc group of all the companies that tend to lose a lot of money, and they're already spending billions buying lobbyists, buying congressmen, buying ads, and they're going to try their hardest with that FUD, fear, uncertainty, and doubt, and they'll do everything on Facebook and ads on TV and newspapers. They'll do everything to scare everybody about doing this universal health care that we've already proven can save us money, but they're gonna tell us it can't.
But you're right, as far as politicians go, it doesn't affect them because they have great health care.
But are
So
they
then
going
they
to
should have what
be in
we
on this
have.
Oh,
one
everyone,
too?
everyone, this covers everyone.
What I was gonna say, when it comes to the lobbyists, just so that you know, the healthcare committee is, the chairman of that, what I read in one of my, things from the group that I belong to, is one of the senators from Tennessee. There's been a bunch of bills put forward in the last 3 to 4 years to try to rein in some of the pharmaceutical companies. For instance, they're paying generic drug companies not to produce the generics for years, okay? It cannot get out of that Senate committee because that senator is he gets maybe 30,000 from Sanofi, he gets another 25,000 from Johnson & Johnson, he gets another 20,000 from Merck, okay? It also happens to all of the representatives in Congress. And when they finish with their congressional term, guess who they become? The next lobbyists, okay? So the lobbyists are a real problem with all of this, as well as the retiring House of Representatives and the senators. So that's why another option is you need term limits, like we have on the president. But
We need to get young people in that aren't bought off already. I think it's pretty exciting, some of these young people that are being elected and they're not being bought off and they're going for the goal.
Yeah, and I suppose that's why, and I bet everybody in this room has signed the dirty money petition to stop money from going to the.
You gotta clean up the money first.
Yeah, exactly.
Well, that's the number one problem in the United States.
Yeah.
Right. We need
Exactly.
campaign finance reform, that's what we need most of all, and that would take care of this, but.
But we have to keep working toward what we really, really, really want. I mean, they've been already working on this since the early 1900s. We've just got to keep working on it until we have a groundswell of people that'll finally say, I just can't,
You know, we got women the right to vote. We got people, women and men on the moon. We should be able to take care of the healthcare problem if the people cared enough to make our politicians do this.
And understood.
It's our responsibility here. We can't just keep putting it off.
that's why we end the program with it's up to us. Because our politicians obviously aren't going to do it for us. It's up to us to spread the word about what we really want and what's possible.
So thank you. I mean, we've been here a very long time.
We're awesome. I think you should run for president.
Thank you so much. It was awesome. Amazing.
Thank you for everybody for being here.
That was great. So nice to meet you.
It was nice to
You
meet
come
you,
back
Susan.
anytime, you hear? Please do.
My
We'd love-
spare time.
In your
Midnight and one.
Well, we'll see if we can accommodate that as well.
No.
Good to see you. Come back whenever you can.
Sure.
Colleen.
you better all get out the vote.
Absolutely. Monday,
Oh, Miss, how's she doing?
97 on April 3rd.
Oh my God, yeah.
She gets excellent care over there.
Yeah, but that's the 1% of the population.
She's, and she's never been obese. She's got nothing wrong with her. She's got some relatively recent dementia.
Well, it's 97, that's a 97, you know, that's to be expected.
She can't walk. But
I said hello. I've been having a good time since I left. I've been traveling a lot. In fact, we just got back from Japan. Well, I shouldn't say us. We got back the last week in October, first week.
just in the nick of time.
Just in the nick of time. I don't know. We just got back.
My niece was on a cruise last month